So coming to COVID-19 and obesity, as we know, the pandemic has resulted in ill health and has definitely affected all of us. But how has it affected children? It has affected children mainly because of interruption in the daily routine. They haven't been going to school, and this has resulted in exacerbation of the obesogenic environment. No physical activity, increase in the screen time, increase in the stress. All this has resulted in the COVID-19 pandemic, also resulting in the global epidemic, which is obesity. So we have definitely noted a gross increase in children with obesity post-pandemic. So how do you classify obesity? So now once we're done with the introduction, we need to go how do we evaluate a child? Suppose a child walks into the OPD and the child is obese. So how do you diagnose what is the cause and what is the issue? So how do you broadly classify obesity? One is physiological, which I mentioned, that is exogenous obesity because of diet and lifestyle changes. But rarely obesity can also be because of pathological causes. So we need to keep in mind, how do we make out it is a pathological cause which requires intervention? So pathological causes mainly are endocrine causes, such as a child with hypothyroidism, a child with Cushing's syndrome, a child with growth hormone deficiency, a child with Turner syndrome, or pseudo hypoparathyroidism. Coming to monogenic or genetic causes, these generally monogenic causes, they present with early onset obesity during infancy or early childhood, and this obesity is associated with hyperphagia. By hyperphagia, I mean increased hunger, increased need for food. There is also food hunting. They go to the kitchen, they hunt for food. They give this classical history of going to the fridge, looking for stuff. So this is a classic of monogenic obesity. It can be a leptin deficiency, leptin receptor defect, or MC4R gene defect. Syndromic causes, if you feel that the child is dysmorphic and has some other associated anomalies, we should think of syndromic obesity, which can be our Bardet-Biedl or Prader-Willi syndrome or Alström syndrome. These are only few of the many syndromic causes of obesity. And last, we come to drugs. Drugs can be, especially our anti-epileptics and our antidepressant medications are known to cause increased weight gain. And hypothalamic secondary to any tumor, secondary to head injury can also result in post-surgery for craniopharyngioma can result in obesity. So I'd like to discuss two cases just to know how do you differentiate between physiological and pathological obesity. So here we have a child who we can see a boy child, 16-year-old. The weight looks okay. The weight is a little high. The BMI, the child's BMI was also in the obesity range. But we can make out that the child's height is very less. The child's height is much less than the third centile, and this contributes to severe short stature. So here we would most likely look at an endocrine cause. So the dictum is a child who is obese and short is an endocrine cause. A child who is obese and tall, it is an exogenous or a physiological cause. So here it could be hypothyroidism, Cushing's disease, or growth hormone deficiency. So here, as I mentioned, the other child, we have a girl child whose weight is high, BMI is high in the obesity range, but the height is also good. So this is a classical of exogenous obesity. So this is how you can grossly differentiate just by plotting it on the growth chart and checking the height of the child. So how do you differentiate? As I mentioned, constitutional or physiological obesity is mainly seen at the age group of 5 to 6 years or pre-pubertal, whereas pathological doesn't have any age prediction. But I mentioned genetic obesity can have early onset obesity or hyperphagia. Family history will be present, can be present in both, but there'll be a definite inheritance pattern in pathological. And on examination for pathological causes, if there is any dysmorphic features, if there is neurodevelopmental delay, if there is fall in the height or the height velocity is not good, but the weight is continuously increasing, that is a characteristic of a pathological cause. And pathological causes most of them will have a delayed bone age, like hypothyroidism, growth hormone deficiency, all of them will have a delayed bone age, and they are known to respond very poorly to lifestyle measures. We need to treat them individually based on what the cause is. So coming to what are the complications? So if we have a child with obesity, what do we look for? What do we evaluate? And what all do we tell the parents? So what are the issues? Why do we need to tell them that it is very important to screen the child for obesity and treat them? because the obesity complications can be numerous, starting from the brain. They can have pseudotumor cerebri, they're known to have metabolic syndrome, dyslipidemia, hypertension, endothelial dysfunction. Type 2 diabetes is very common now in children and adolescents. Precocious puberty, PCOD resulting in irregular menstrual cycles, hirsutism. They can have joint pains, bone pains, limping because of slipped capital femoral epiphysis or Blount's disease. They can have gallstones causing pain, stomach pain. They can also have steatohepatitis or non-alcoholic fatty liver disease. They can also have sleep apnea resulting in excessive sleep during the school hours because they're not getting enough sleep during the night. Exercise intolerance. They can also have other psychosocial effects like poor self-esteem, depression, or eating disorders. So this is a vicious cycle. So we have a healthy child, as I mentioned, because of pandemic, the child has completely been studying on inappropriate food and increased screen time. Child becomes mildly obese. Once the child becomes mildly obese, there is exercise intolerance. So the child is not able to climb the stairs, not able to play, not able to be active. This results in increased weight gain, resulting in moderately obese, and again, exercise becomes painful, child becomes severely obese, and then the child becomes an obese adult because, as I mentioned, from childhood it spills on to adulthood. And and that's when the complications also begin. So what are the consequences? Type 2 diabetes, as I mentioned, is a very important, and insulin resistance is the main cause of type 2 diabetes and obesity. So the ADA has come up with a guideline saying all children with BMI more than the 85th centile with two risk factors, which would be a high risk ethnic group, all Indians fall under this, any affected first or second degree relative with type 2 diabetes, or any signs of insulin resistance such as acanthosis nigricans. All of these will suggest screening for those children. So any child who walks up to your clinic with obesity, that is BMI more than 85th, with any of these two risk factors, we have to screen them for type 2 diabetes. So when do we start screening? Either at 10 years of puberty and every 3 years if it is normal. So how do we screen? We do a HbA1c. If it is more than 6.5, we do a fasting plasma glucose in 126 and 2 hours plasma glucose more than 200, or even a random glucose. If there is a classical symptom of type 2, random more than 200 is also kept as the diagnostic criteria. Coming to dyslipidemia in obesity, it has been noted that there is elevated triglycerides, elevated LDL, elevated total cholesterol, and decrease in the HDL. So this is a multiple there's a combination of multiple entities which are involved, and this is supposed to be very atherogenic. Can result in atherosclerosis and cardiovascular side effects such as stroke and cardiac arrest in later adulthood.